so I'm going to try to flip through a bunch of slides. Happy to, kind of discuss in greater length, but we're going to cover quite a number of different areas. I actually heard Joel give his first talk on lung transplant back in the 80s. If you're going to compare where we come from, et cetera, it's actually pretty fascinating. The first one was done. The first successful one was done in '83. If you look at the UNOS data, the 1-year survival in '87, which was the first time that they actually captured enough patient, was only 33%. As we've moved on, in '93, when I first started on faculty, your benchmark for 1-year survival was essentially 75%. So you could be losing 1 out of 4. By 2003, it's up to 84%, and we were doing primarily CF and COPD. Now we're doing almost 55 to 60% is IPF, and our 1-year survival to stay out of UNOS hell is about 85%. 5-year survival back in the 80s, 16%. That would be somewhat similar to most cancers. Right now, if you're under 55 and we transplant you with a double lung, our median survival is now approaching 10 years. So we're evolving to be very similar to where heart and liver and kidney transplants are. And the interesting thing is the primary indication back in University of Toronto in the early 80s was IPF. They weren't sure they could do COPD or CF or anything else. We went through a phase where we were doing all COPD and CF, and now we're back to doing predominantly pulmonary fibrosis. Wait list in the early 80s, you could say, what wait list? It was just whether you actually could figure out if somebody was transplantable or not, and you had all the various organs you would want. In the early 90s and early 2000s, it was just time on the wait list, and then we've switched over to much more of a need-based. The LAS system, or kind of a need-based system, was introduced in May of 2005, and it fundamentally shifted who got transplanted. So we're no longer doing the people who can live longer once the diagnosis is made to people who actually are going to hopefully benefit more. There's also an increasing intensity of the disease. So we're now transplanting the sickest first, and then the less sick, frankly, are going to wait. The use of ECMO as a bridge, the use of mechanical ventilation have all increased, and the use of ambulatory ECMO to get people to transplant. And the thing that's probably the most interesting, Paul brought up that the fact that IPF occurs in the 60s and 70s. Well, now 25% of transplants in the United States are done in a population over 65 in which the ISHLT guidelines suggest that over 65 is a contraindication to transplant. So a quarter of our patients are outside of our guidelines. Trying to explain the LAS is essentially what you're looking at is the essentially survival benefit by not getting transplanted, i.e. what's the survival curve in the area under it, versus the survival benefit of being transplanted. As you subtract that difference between the gray area on the right versus the gray area on the left, that's your overall benefit. You can kind of look at it this way. If you were going to be 100% alive after transplant and 0% alive not being transplanted, you would have the highest priority. If you had no chance of being alive after transplant and 100% alive with transplant, you'd have a 0. So the allocation curve essentially recognizes that and it moves. The other component of it, as you get sicker, you move into a different area on that score. So the LAS is normalized from 0 to 100, with, frankly, the patient who's sickest and has the most transplant benefit having the highest priority. And the aspect of how it moves from as a patient gets sicker, as Paul's patient needs more oxygen, he or she will move up on the allocation system. So this is just looking at some of the issues in terms of who are we transplanting. So that green curve on the left is the LAS score over 50. Well, to get an LAS score over 50, by and large, your baseline oxygen requirements have to be over 8 to 10 liters, or you're on a ventilator, or you're on ECMO, et cetera. Then looking at that age over 65, that green curve, that used to be 0, essentially. Now it's literally over a quarter nationally. At Duke, it's over 50%. Over half of our transplants are now done over the age of 65. And I will not tell you on the surgical end, it's a hell of a lot of fun to be taking care of these patients. But the problem is, I can't show you that they do any worse than any other patient population. These are looking at the curves of under 60, 60 to 69, and over 70. And up to 2 years, we can't tell any difference. We can tell you in the ICU and in the care immediately after the transplant, it's like you're transplanting a different species. But once they get through that acute phase, they seem to do exactly the same as everyone else, other than that they die not based on what happens with the lung. They die based on infection, organ failure, and then somewhere down the list is how the lungs are doing. As compared to your 20-year-old cystic, it's always around how do the lungs do, how do the lungs do, how do the lungs do. We mentioned kind of the bridging with ECMO. Well, this Avalon catheter that you stick through the right IJ, didn't think you could put in as big a cannula as you can. But in a big guy, you can put in a 31 without any problem, and the smaller women, et cetera, you can get 27s. You can get essentially full ECMO flow. I will never tell you, go with an Avalon when they're crashing and burning, bridge them some other way, but you can put these things in and convert them. And it becomes this an entire cluster to try to get them up walking, but it is amazing that you can actually have them walking around the hospital, et cetera. And the importance of it is literally that we have been able to take the patients who are bridged off ECMO from being these 2 to 3 month hospital stays after their transplant to more like 3 weeks. So they become essentially the same as anyone else getting a transplant. And this is literally one of the biggest growing populations in lung transplant. Just kind of looking at the more recent cohorts of patients who were bridged off ECMO. This is very similar to the experience of bridging with VADS to heart transplant. It used to be that the 1 year survival was more like 60%, 50% if you bridge somebody on ECMO. This is from the UPMC group, and this is very typical of kind of the major centers' experience. They have essentially survivals, 30-day, 1 year, and 4 year of 100%, 88, and 88%. That is essentially what we would expect for all comers. So literally, if you are properly selecting your patients, they can have outcomes that are very, very similar to other patients. I'm not saying that when you're transplanting the very, very sick that they're going to do as well, but they can have every bit as much of benefit or more than some of the other patients that we had classically transplanted. So in lung transplant, what are the priorities? What are the major issues? Well, it's always going to be around not enough organs. There's always been this issue of PGD, or that the organs didn't work particularly well immediately afterwards, and dealing with the very sick patient after transplant. And then probably the fundamental problem is that our long-term allograft function has just never been good enough. I mean, the reality is a median survival of 6 or 7 years on the national data. That's not what we really want. If you're going to transplant a 15-year-old, you don't want to talk about 6 or 7 year survival. You want to be talking about decades. And fundamentally, we're not there. And then the issues about the toxicity. I stole this from a heart transplant and put the lung, but it's the same thing. There's always going to be more people that could benefit than we can actually transplant. Let's put this in perspective. Lung failure is the 4th leading cause of death in the United States. It's between 124 and 126,000 deaths per year. There were 1,800 lung transplants. That's a pretty significant shortfall. So let's say that only 10% of those lung failure patients who die would be candidates. We're still looking at a tremendous shortfall. Large centers now are routinely doing more than 100. There are now 6 centers in the United States doing more than 100 lung transplants in a year. We think that we're probably going to go somewhere between 200 and 300 over the next 2 or 3 years. And this is very typical of almost any solid organ as you look at the evolution over time. As soon as it becomes more of a commodity therapy or standard between, it will start decreasing. But as certain centers figure out that this is actually not that hard to do, that you can put the infrastructure in, they start growing. If you look at liver, for instance, they were at this stage about probably 15 years ago, where a large liver transplant program was doing 500 livers. Now they're back down under 300, so a big program is going to be in the 200s, et cetera. Looking at liver transplant, it's the 12th leading cause of death, only 27,000, yet they do 6,300 livers per year. So about a quarter of the patients who have liver failure actually end up getting transplanted. Their organ utilization rate is 87%. In lung, it's only 17%. I would submit that we've got some opportunities to improve how many transplants we do just by a better utilization of the organs that are there. Just some of the technologies that are coming. So you may have heard of EVLP or lung in the box. This is what kind of one of the lungs looked like beforehand. This is what it looks like afterwards. I'd submit that maybe you could have used the one on the left, but you sure are going to feel a lot more comfortable using the one on the right. This is actually the Toronto group's New England Journal paper looking at the initial results. And the long and the short of it, I'm not going to ask you to look at the small text, but the outcomes were exactly the same. If you got a lung that had been turned down, put on the rig, improved to the point that they wanted to use it, your outcomes are the same in terms of PGD, in terms of survival, et cetera. And the long and the short of it is they were taking approximately 85% of the lungs that they were trashing and now utilizing. This is an update. These are abstracts that are going to be presented at ISHLT this spring, looking at 3 of the largest centers and then the FDA trial that we're involved in to try to get this technology approved in the United States. And the long and short of it is that the outcomes are equivalent on organs that would have been otherwise turned down. Certainly the early mortality and the midterm mortality is the same. Now there is a difference between what the Toronto group has found in terms of utilization, more in the 80% range, whereas in the FDA trial it looks like it's more like 50 to 60%. But regardless, these are organs that would have otherwise been turned down. So the current strategy is right now just trying to increase the utilization of those 83% that are currently not used. But what we're really trying to do is get to a different stage. Now, you may or may not know about the Maastricht classification of what we call DCD, or death after cardiac death. The majority of the ones that we're using now are people who have irreversible brain injury, not brain dead. We withdraw in the ICU or in the OR, and yes, we can extract organs from them and do it. The real question is, can we take the DCDs, or the sudden deaths that occur in the emergency room, out in the field, and be able to extract the lungs from there? And the reason is that there are about 700 and, nominally 80,000 sudden deaths in the United States every year. When we talk about 124,000, suddenly we potentially have a donor pool that would actually take care of every single person that would be an appropriate donor. And I'm not asking you to look at, but things to do to resuscitate organs or to make them better. Use of carbon monoxide, of various adenosine receptor antagonists. There's a laundry list of things that are being tried in animal models that frankly are working. Once we have the actual technology platform, there's the potential of being able to use lungs that we never ever would have thought were usable. I'm going to shift gears a little bit and just talk about kind of the variability from center to center. This is the lung transplant outcomes group. This is Jason Christie's NIH-funded trial. 10 different academic centers. On the right-hand curve are the centers and their rates of PGD. They range from 3% to 25%. That's the variability within the lung transplant community around it. I'm not going to divulge any of the identities of the programs, but the 3% program happens to be the largest program. The 25% is also a large program. And some of the things that they're teasing out from this, use bypass, you're going to have, so if you're routinely doing your lung transplant on bypass, you're much more likely to have PGD. If you reperfuse in a setting in which you're on 100% oxygen as compared to very low levels of oxygen, you're much more likely to have PGD. There are technologies or processes that can be done to minimize the amount of essentially graft dysfunction that just need to be disseminated across the lung transplant community. And the curves on the left are some of the associations. Some of them you can control. Some of them you can't. You know, if your patient has pulmonary hypertension, your patient has pulmonary hypertension. Now, you can initiate therapies to try to lower it. But other things are actually within the control of the surgeon and the transplant group. And the data on the bottom is just the continued importance. If you don't have PGD, you know, your rates of death at 1 year are around 10%. If you do, the rate of death is about 34%. Pretty important to control that if it's a controllable factor. I'm going to switch gears a little bit. So those of you who have been exposed to lung transplant got very used to BOS, or bronchiolitis obliterans syndrome, or pulmonologists are going to throw a few hooks into that. So now we talk about CLAD, or chronic lung allograft dysfunction, of which it's the same definition as BOS. It's just a 20% drop in your FEV1. This has always driven me a little bit nuts, because if I said after a kidney transplant you dropped your creatinine clearance by 20%, that you had whatever that is, renal allograft dysfunction, et cetera. Well, that's the equivalent. So it's a very primitive. There are a lot of different ways of getting there. But there is an importance in terms of what we talk about bronchiolitis obliterans syndrome, which is an obstructive process, versus what has been classified as a restrictive syndrome. And when you look at the survivals of BOS, clearly if you have CLAD, you don't do as well. But the survival with BOS is, compared to RAS is substantially different. And I'm not going to go into all the different things, but there seem to be fundamentally different both mechanisms of getting there and mechanisms involved with the fibrotic pathways that are probably much more aligned with pulmonary fibrosis. And it does bring up some interesting research things. Now, what can we say about the long term? These slides are from the ISHLT, so you get a lot of data. Primarily it's from UNOS, but from other countries as well. And the fundamental difference has always been in the early hazard, or what do we do in the first 3 months. If you look at beyond the first 3 months, the curves are parallel. You could even say that the green curve, which is the most recent, has a sharper decline. You know, we did better at the beginning, and then we seem to lose ground afterwards. So we don't seem to be doing very well in terms of long-term function. This is kind of a comparison of eras, so you know the 10 years from 94 to 2003 versus the most current. If you look at hypertension, renal dysfunctions, bronchiolitis obliterans syndrome in the first year, and you're not supposed to see very much, they're all equivalent or higher. Now that could be just data capture and that we're doing better at capturing all the events that happen, but we certainly aren't getting any better. And it's just looking again, the 5-year phenomenon of BOS is about 40%. That's probably an underestimate. And then you get out to the 10-year, and almost 2/3 of the patients have bronchiolitis obliterans syndrome, or CLAD now. But also look at the other components, the 75% renal dysfunction rate, essentially 15% of the patients either needing dialysis or getting a renal transplant. So substantial morbidity from our drugs, et cetera. So one of the other components of this is what have we found that may be relevant to trying to improve this. And we've had a longstanding interest in the aspiration component as related to GERD, et cetera. But there's also some very interesting data that's come out of the Europeans linking the amount of air pollution exposure in a lung transplant and their outcomes. And this is just looking at the differences if you were living greater than 1,000, I think it was meters away from a, essentially an index road, or essentially would be equivalent of an interstate or something along those lines. And differentiating both the freedom from BOS and overall survival. And they actually tried to fit this over, I actually may have had that wrong. It may have been more like 300 meters or something like that. But they went ahead and did hazard functions looking at distance from these roadways. And that the hazard, as you got closer and closer, increased at a fairly exponential rate. kind of an interesting thing. So what do you tell your lung transplant patient? Well, probably don't live next to a coal plant and maybe stay away from the other components. But in some ways, it may be a correctable component. This is our index case of a patient who we had done a lung transplant back in the early 90s. And we used to be small enough that we could actually do team rounds up on 7800 where Paul's pulmonary patients. So this kid had transplant, got up to 3 liters, developed what we thought was classic BOS. We did all sorts of immunosuppression, modulation, et cetera. Gave up, retransplanted him. Thought we were doing great. He gets readmitted on this phase here. Kid had the worst reflux symptoms I think I've ever. So we just sent him, got a barium swallow, documented reflux, gave him a fundoplication, and this was his curve. And this is his drop-off when he developed dialysis or chronic renal failure requiring dialysis. So I'm not going to go through all the different things. We had demonstrated that you do fundoplication in patients who have drop in FEV1s and have documented reflux, and we could show that there was a 25% increase. So we said, well, maybe we do this as a preventive strategy. And if you do that in the patients who had documented reflux and did early, you could certainly reduce the amount of BOS that developed and also prevent death. Then if you want to look at this as both Cleveland Clinic and Duke have both kind of looked at what happens if you have abnormal pH or if you had reflux disease going in a transplant. Your actual graft failure or graft function is substantially worse than if you didn't have it. And if you did a fundoplication in those patients, you could abrogate any of those losses. So you can make the lungs work better. Now, Paul may not believe that doing this in the IPF population with reflux, but that actually may get funded, from what I understand. Now, the other major interest is in essentially antibody-mediated rejection, or AMR. And the only reason I bring this up to some degree is that it is one of the hot areas in lung transplant. There were probably about 25 abstracts that are going to be presented at ISHLT this year. And fundamentally, what's the problem? Well, one, we can't make the diagnosis very well. The lung is a very difficult organ to demonstrate antibody deposition in for a variety of reasons. Once the lung gets injured, it starts to shed much more than almost any other organ. The wobble Pilati body release, et cetera, can create all sorts of things, and then it leaks, so the proteins get in non-specifically. So if you have PGD, you can demonstrate complement over it. So long and short of it, making the diagnosis is not very easy. But if you have donor-specific antibody and allograft dysfunction and or abnormal pathology, this is data from UCLA, regardless, your outcomes are very, very poor. So trying to be able to address this is a major area of interest. Well, we've got all sorts of tools that are supposed to be able to remove these antibodies, plasmapheresis, rituximab, IVIG, and one of the proteasome inhibitors, bortezomib. So we got all the tools, right? Well, these are 2 of the 3 abstracts, and there's a third. So Duke, WashU, Toronto, none of this works. We can throw the kitchen sink at them, and our outcomes in patients who have AMR and allograft dysfunction are terrible in terms of mortality, in terms of being able to maintain the organ function. So long and short of it, these are areas of ongoing investigation that have to be addressed for us to do better with this. And I'm going to close with kind of, the things that aren't supposed to be, the holy grail of transplant. So, tolerance in xenotransplant, I guess, are the things that tolerance and xenotransplant are the future and always will be. And maybe not. So this is Laura Margaret was very interesting story. She has combined immunodeficiency disorder, if you can think boy in the bubble kind of problems. Well, they die usually from bronchiectasis if you can keep them alive long enough. So they have no immune system, and they die of usually lung failure if you can get them into their teenage years. She actually was a pregnancy that was planned because her brother had this, and they wanted to do a stem cell transplant or a bone marrow transplant from her to her brother, and unfortunately, she had the disease as well. So this is an interesting opportunity in that you have a reason to do a bone marrow transplant because they're immunodeficient, and you have a reason to do a lung transplant because they're dying of bronchiectasis. In the renal world, they've done a lot of kind of tolerance trials using living donors. It's never been done really in cadaveric. So we have a pilot study going on for these individuals in which we're taking cadaveric donors. We require a 3 out of 6 HLA antigen match, so it's not an easy process. You have to sort through a tremendous number of donors to finally get one that works. We do a lung transplant. At the time of the procurement of the lungs, we extract the bone marrow. You can imagine we've got quite the access between the iliacs, the spine, and everything. We can get marrow. That's not usually a problem. We get them out about 2-3 months from the transplant so that the innate immune system has become more quiescent, so the inflammatory component. And then we go ahead and hit them with the full bone marrow protocol. So they get essentially their marrow ablated and they get reconstituted. This kid is now, I think she's a junior in college. She was a sophomore or junior in high school at the time. She is on no immunosuppression, has been on no immunosuppression now for 2 years. Her FEV1s continue to climb. She's never had any rejection, and she is completely immunocompetent. So she is truly tolerant. We've done the second one. We're not sure that we're in the drug withdrawal side of the equation. But it is possible now to have a platform that we might think could be used in that 15-year-old cystic or that 20-year-old cystic, that we can talk about maybe lifetime treatments. And in some ways there is hope. It's always with risk. So I'll conclude and say, lung transplant continues to grow. I honestly think that we probably should, even with the current technologies, be doing more like 4,000 to 5,000. You're going to see some programs that literally are going to be doing 250, 300 lung transplants in a year if they can get their infrastructure needs. There are so many more patients that we're not fighting over patients. The reality, this isn't dividing the same pie. This is actually getting out and communicating to the pulmonologist that 70-year-old IPF patient who's on oxygen needs to be referred somewhere. It doesn't have to be your center. They need to be evaluated because you have something that may add 5 to 7 or 8 years of life. There's not much we do in cardiothoracic surgery that reliably can add that number of years of life. The recipients are clearly getting older and sicker. We can ascertain, but the reality is we got to take care of the people who are going to benefit the most. The outcomes continue to improve. I would expect that by the next time, if you did this 10 years from now, the benchmark will be more like a 90% one-year survival. And the question is, how good do you have to be? Are you doing too much, essentially picking if you're doing too well? We've got to overcome the outcome variability. I showed PGD, but the same thing happens in terms of survival. We've got to get this to the point that it becomes more like commodity care and that everyone's doing very similar. Chronic allograft dysfunction remains our major Achilles heel, and we haven't made much of an impact. Now, you could say probably the same drugs that are going to work for IPF are going to work here. We want to see them. We keep working on it. But we don't have that right now. Thank you very much. I'm happy to take questions.